Buenas tardes. Pues irán subiendo posiblemente bastante de los oyentes que están en la sesión plenaria abajo, que va con un poquito de retraso, pero nosotros pues la verdad es que tenemos que mantener el horario previsto. Me llamo Eduardo Miñambres, yo soy coordinador de trasplantes del Hospital Marqués de Valdecilla y médico intensivista. Voy a ser director de esta mesa, junto con mi colega Irene Bello, cirujana torácica del Hospital Clínic de Barcelona. En esta mesa redonda realmente lo que vamos a hablar es de tres tópicos completamente diferentes, tres temas totalmente diferentes, pero realmente de un impacto muy importante. Donantes con tumor, ¿cuándo es posible? Haremos un cambio en el orden de los ponentes. El doctor Sipel será el segundo ponente. Realmente el trasplante de pulmón en pacientes con distrés agudo tras COVID, algo que realmente en España hemos empezado a hacer, que no pensábamos que fuera posible y que lo cierto es que es una realidad. Y finalmente hablaremos sobre un tópico completamente distinto, que es la recuperación de la función sexual en el paciente trasplantado, si es un mito, si es verdad o es ficción. Y así que para ello tenemos unos ponentes excelentes. Yo creo que para empezar y para poder tener tiempo suficiente, vamos a hacer una charla y después de cada charla haremos un debate y preguntas específicamente al ponente. Empezamos con la doctora Beatriz Domínguez Gil, directora de la Organización Nacional de Trasplantes, que va a hablar de la actualización y manejo de los órganos de los donantes con patología tumoral.
Muy buenas tardes a todos y gracias por invitarme a abordar este tema relativo a la actualización y manejo de los órganos con patología tumoral. Bueno, todos sabemos que el trasplante es una terapia que ha alcanzado un éxito impresionante. En el año 2020 fueron 130.000 los trasplantes de órganos que se realizaron en el mundo y tal ha sido el éxito del trasplante que apenas cubrimos con esta actividad abrumadora el 10% de unas necesidades globales que siguen creciendo. Pero como cualquier intervención, como cualquier acto en medicina, el trasplante de órganos conlleva una serie de riesgos, incluyendo la posibilidad de transmitir enfermedades de donante a receptor, incluyendo tumores procedentes del donante, algo que se conoce desde los principios del trasplante, como podéis observar en estos artículos de la década de los 60. Cuando hablamos de transmisión tumoral es importante diferenciar estos dos conceptos, el tumor transmitido del tumor derivado. El tumor transmitido está presente en el donante y en el injerto en el momento del trasplante y el tumor derivado no está en el momento del trasplante, pero se desarrolla a partir de células del donante una vez se ha efectuado ese procedimiento trasplantador. Conceptualmente es importante esta diferencia, pero en la práctica es complicado. En el caso del tumor transmitido, a priori todos los receptores del mismo donante están expuestos a un riesgo de transmisión tumoral y este no suele ser el caso en el tumor derivado. En cualquier caso, la diferenciación es muy complicada en la práctica y normalmente cuando hablamos de tumores transmitidos muchas veces incluimos tumores derivados del donante. ¿Con qué frecuencia ocurre esta complicación? Pues los primeros estudios derivan de este registro de Israel Penn, un discípulo de Starsell que inició un registro de tumores post-trasplante en la década de los 60 y que hizo unas estimaciones del riesgo de transmisión tumoral que hoy sabemos que probablemente eran sobreestimaciones por diferentes motivos metodológicos, pero sobre todo porque este registro tiene carácter voluntario, con lo cual tenía los numeradores de los tumores que se habían transmitido, pero no los denominadores de los receptores expuestos a un riesgo. Por ejemplo, en tumores del sistema nervioso central grado 4 llegó a estimar riesgos de transmisión de 30% para un meduloblastoma o 40% para un glioblastoma. Recuerden estos porcentajes porque luego volveremos a ello. A día de hoy probablemente tenemos una visión mucho más clara de cuál es la dimensión verdadera del problema y el riesgo de transmisión tumoral gracias a estudios de registro que tienen ya un carácter mandatorio, un carácter obligatorio, con lo cual disponemos del numerador y disponemos del denominador. Esta es, por ejemplo, la serie española que acabamos de publicar en Transplantation. ¿Y qué sabemos de estos estudios de registro? Bueno, en primer lugar, que utilizamos con cierta frecuencia órganos de donantes con patología neoplásica, de manera que vienen a representar entre un 3 y un 4% de nuestros donantes, que es un porcentaje nada desdeñable y que probablemente vaya aumentando con el tiempo según envejecen nuestros donantes y tenemos más supervivientes de cáncer gracias a los avances en la terapia o en la patología tumoral. Pero estos registros también nos han dicho que se producen transmisiones tumorales. Lo que pasa es que nos dicen que en la mayor parte de los casos esos tumores no los conocíamos en el donante, era un tumor oculto en el donante y que se transmitían al receptor con una frecuencia que podéis observar que oscila entre los 3 y los 6 casos por cada 10.000 pacientes trasplantados. Y normalmente, en la mayor parte de los casos, salvo en casos de tumores derivados, se trata de tumores muy agresivos histológicamente. Por lo tanto, una frecuencia frecuencia baja, pero vamos a ver que tiene un impacto extraordinario. De hecho, cuando hablamos de transmisión tumoral, hablamos casi de David y Goliat. Ocurre muy pocas veces, pero cuando se transmite un tumor a través del trasplante, el efecto es devastador. En primer lugar, en los pacientes afectados. Esto es una revisión sistemática de la literatura en trasplante renal que identifica 234 pacientes con un tumor transmitido y simplemente destaco algunos aspectos. De la histología, lo más frecuente era el linfoma, el cáncer de células renales y el melanoma. Estos tumores transmitidos se diagnostican pronto después del trasplante, fijaos que el 84% en los 2 primeros años, pero cuando se diagnostican, en la mitad de los casos el tumor ya ha metastatizado fuera del órgano y fijaos que en el ámbito del trasplante renal lo habitual es que se realice, o es muy frecuente que se realice trasplantectomía, evidentemente con o sin quimioterapia, radioterapia o inmunoterapia asociada. Y fijaos el impacto tan tremendo en supervivencia. A los 2 años hay una probabilidad de supervivencia después del diagnóstico de aproximadamente el 65%. En esta revisión sistemática también identifican factores relacionados con el pronóstico de estos pacientes tras la transmisión tumoral, algunos muy evidentes como la metástasis al diagnóstico o el tratamiento de paliativo, pero fijaos sobre también la histología del tumor, lo que cambia el pronóstico. En el caso del cáncer renal, la probabilidad de supervivencia es elevada y, sin embargo, en el melanoma o en el cáncer de pulmón, la probabilidad de supervivencia es muy reducida. Muy recientemente se ha publicado esta revisión sistemática en el ámbito del trasplante no renal. Fijaos que son 73 trasplantados con un tumor transmitido y básicamente el mensaje es muy parecido al que hemos visto en el ámbito del trasplante renal, salvo en 2 aspectos. En primer lugar, que como podéis observar, el retrasplante es una posibilidad que se ofrece o se plantea en un número muy reducido de casos y solo en el ámbito del trasplante hepático, y el impacto en supervivencia es muchísimo peor. Fijaos que solamente hay una probabilidad de supervivencia de 39% al año y prácticamente todos los receptores pulmonares, con un tumor transmitido en esta revisión fallecieron en el primer año después del diagnóstico. Y como factores pronóstico, destacar el papel del retrasplante. Cuando existe posibilidad de retrasplante, que normalmente son tumores localizados en el injerto, fijaos cómo la probabilidad de supervivencia es mucho mayor que cuando esta opción terapéutica no existe. Por tanto, efecto devastador en los pacientes afectados, pero también hay otros efectos de los tumores transmitidos. Tienen un importante efecto en el estado mental de los profesionales sanitarios que están atendiendo a estos pacientes o que han tenido un papel en la evaluación de ese donante o en la extracción del órgano. Este concepto de la segunda víctima, que es el profesional sanitario, está de hecho muy bien reconocido cuando hablamos de seguridad del paciente. Y hay una tercera víctima en caso de la transmisión tumoral, que es el propio Sistema Nacional de Salud, sobre todo cuando tenemos casos que tienen una repercusión mediática. Este fue el caso de este cáncer de mama transmitido en Alemania a 4 receptores renales, que tuvo una enorme repercusión en los medios y que evidentemente pone en tela de juicio todos nuestros protocolos de actuación y cuánto de seguro y cuánto de bueno puede ser el trasplante. Por lo tanto, el impacto es devastador, aunque la frecuencia es muy reducida. Cuando nosotros nos planteamos qué hacer ante la patología tumoral en un donante, realmente nos deberíamos plantear 2 objetivos igualmente importantes. Por una parte, tenemos que minimizar la ocurrencia de esta complicación, pero por otro lado tenemos que evitar la pérdida innecesaria de órganos para trasplante que podrían ser perfectamente válidos al menos para determinados grupos de pacientes. A la hora de abordar o conseguir estos 2 objetivos, todo empieza con la caracterización, evaluación y selección del donante en general y del donante con patología neoplásica en particular, lo que podemos considerar que es un proceso multidisciplinar, un proceso en el que van a participar numerosos profesionales y que tenemos perfectamente guiado a través de documentos que están vigentes en nuestro país y del que voy a destacar algunos aspectos. En primer lugar, en la caracterización, todo empieza en la UCI, en la valoración del potencial donante, a cargo sobre todo del coordinador de trasplantes. En caso de que identifiquemos un donante con patología tumoral, recordemos la importancia de documentar bien el caso, qué histología, qué grado, qué estadiaje, qué tiempo libre de enfermedad, qué tratamiento ha recibido este paciente. En ese caso sí se pueden realizar determinaciones de marcadores tumorales que han servido para la monitorización del tumor en ese donante y determinadas pruebas de imagen, un TAC tóraco abdominal e incluso, por ejemplo, en tumores de alto grado del sistema nervioso central, un TAC cérvico-tóraco-abdominal. Y, por supuesto, en la extracción hay que revisarlo todo, incluso los órganos que no van a ser aptos o susceptibles de trasplante. Insisto, es un proceso multidisciplinar y todos los profesionales que intervienen en la evaluación del donante, en la extracción del órgano y en el implante tienen su papel y tienen su rol en este proceso de caracterización del donante. Bueno, nuestras guías, nosotros estamos trabajando con las guías del Consejo de Europa, hay otras guías en el ámbito internacional, nos permiten, en donantes que tienen una patología tumoral, clasificarlos en diferentes niveles de riesgo de transmisión. Insisto que nosotros manejamos la guía del Consejo de Europa, pero nos dice, ante un donante con patología tumoral, ustedes tienen que clasificar en uno de estos niveles de riesgo a ese donante. Puede ser un riesgo considerado mínimo, que podríamos utilizar el órgano para cualquier paciente en lista de espera sin ninguna precaución particular, de riesgo bajo a intermedio, quizá esos órganos serían adecuados para pacientes que a lo mejor tienen una expectativa de supervivencia de semanas, como un receptor con un MEL por encima de 30. El tumor de alto riesgo podría ser también aceptable, por ejemplo, para una urgencia cero o para un MEL por encima de 40, por poner algún ejemplo. Y luego tendríamos los tumores de riesgo inaceptable con un tal riesgo de transmisión que podemos considerarlo ya definitivamente una contraindicación absoluta para la donación. Bueno, en las guías españolas, que emulan las guías del Consejo de Europa, tenéis un número importantísimo de tumores clasificados como riesgo mínimo, intermedio, bajo, alto o inaceptable. Tumores identificados en la historia del donante o tumores identificados en el proceso de donación. Esa clasificación se ha hecho en base a la evidencia disponible y en base a la historia natural de la patología tumoral correspondiente. Por poneros algunos ejemplos, los tumores del sistema nervioso central del grado 1 o 2 de la OMS se consideran de riesgo mínimo, también los tumores renales pequeños de menos de 1 centímetro, de grado 1 o 2 de Fuhrmann, pero por ejemplo de riesgo bajo intermedio, ahora se consideran los tumores del sistema nervioso central grado 3 de la OMS, siempre que no exista una derivación ventriculoatrial o ventriculoperitoneal que nos movería a riesgo alto, o por ejemplo de riesgo alto se consideran los tumores del sistema nervioso central de grado 4, siempre que no tengan derivación ventriculoatrial o ventriculoperitoneal. Por tanto, muchos tumores clasificados que nos pueden servir en nuestro proceso de toma de decisiones. Bien, esta clasificación está continuamente en revisión, entre otras cosas porque vamos generando evidencia. Esta es una revisión que hicimos en esta conferencia de consenso de la ILTS y de la Sociedad Española de Trasplante Hepático, donde de todos los registros que antes os he comentado, recopilamos información de donantes con tumores del sistema nervioso central. Y fijaos, llegamos a identificar más de 77 donantes con tumores grado 4 de la OMS que se consideraban de alto riesgo, es decir, con un riesgo de transmisión superior al 10%, según la clasificación que antes os he presentado, y más de 338 receptores trasplantados de estos donantes. De estos 338 receptores, solo se produjo una transmisión de un glioblastoma a 3 receptores. Por lo tanto, estamos hablando de un riesgo de transmisión inferior al 0,1%. Probablemente estos son tumores de los que carecemos de muchísima información relevante, pero es cierto que hemos sobreestimado durante muchos años el riesgo de transmisión de esta patología neoplásica. Recordad lo que os conté antes de la valoración que se había hecho con el registro de Israel Penn. Por lo tanto, estamos ahora incluso reconsiderando qué hacer con estos tumores de alto grado. Si decidimos ir adelante con un trasplante de estas características, ¿qué tenemos que hacer? ¿Qué deberíamos hacer según las guías? Ya hemos dicho que requerimos una valoración detallada del donante. También necesitamos un consentimiento informado específico del receptor. Y esto es algo que no le deberíamos presentar el día que recibimos esa oferta de ese órgano. Probablemente es un consentimiento informado que tenemos que discutir con el paciente y además discutir reiteradamente según ese paciente evoluciona en lista de espera, porque a lo mejor el paciente a día de hoy no está dispuesto a recibir este tipo de trasplante, pero si su situación clínica empeora, a lo mejor sí está dispuesto a recibir este tipo de trasplantes. Hay que hacer un seguimiento ad hoc del receptor cuando asumimos un cierto riesgo. Consideramos que el TAC es la herramienta más adecuada, que debería realizarse de manera reiterada en el tiempo. Y muy importante, si asumimos este riesgo, tenemos la obligación de ayudar a generar evidencia. Y tenemos un programa específico en España, del que posteriormente os hablaré, el programa de donante de riesgo no estándar. Ahora, el tumor lo podemos identificar en el donante, en su historia clínica, en la evaluación del donante durante el proceso de donación, pero a veces el tumor aparece después de que el trasplante ya se ha efectuado. Y os voy a poner en 3 escenarios en los que seguramente os habéis encontrado en más de una ocasión. Se está haciendo la cirugía de banco del riñón y el corazón o el pulmón ya se están trasplantando. Es un tumor que no conocíamos, ahora conocemos y nos ha cambiado totalmente el riesgo y totalmente la situación a la que nos vamos a enfrentar. Nos aparece nueva información del donante de la que no disponíamos cuando trasplantamos, por ejemplo, una autopsia o una biopsia definitiva de una biopsia intraoperatoria que se informó como benigna. O, por ejemplo, tenemos un receptor con una sospecha de transmisión tumoral que era oculta o que no conocíamos en el donante. De acuerdo a nuestro marco regulatorio, tenemos la obligación en este momento de realizar una alerta de biovigilancia. ¿Qué implica la alerta de biovigilancia? Pues como su propio nombre indica, alerta, lo primero, investigación y manejo o gestión del caso. La alerta fundamental. En cuanto detectamos una situación como cualquiera de las que he planteado, tenemos que ponernos rápidamente en contacto con el responsable de biovigilancia de nuestro centro, que en nuestro caso es el coordinador de trasplantes del centro, quien va a ayudarnos a alertar a todos los centros que tengan receptores en la misma situación procedente del mismo donante, al establecimiento de tejidos y al centro donante. Porque con todos tenemos que empezar a hacer una investigación colaborativa y a hacer una gestión del caso de manera colaborativa. ¿Qué tenemos que investigar? ¿Se nos ha perdido algo en el donante? A veces nos hemos encontrado con anatomías patológicas de un donante que habían pasado desapercibidas. ¿Cuál es el riesgo al que ahora nos enfrentamos? Yo partía de un riesgo mínimo o estándar, no había tumor y ahora resulta que tengo un tumor de riesgo inaceptable, de riesgo intermedio. ¿Qué riesgo tengo ahora? Y por otra parte, si tengo una sospecha de transmisión tumoral, ¿realmente este tumor procede del donante? O puede ser un tumor de novo en el receptor o una recidiva de un tumor previo de ese receptor. Hay que hacer una investigación y esto es una investigación colaborativa de datos clínicos e histológicos, situación de otros receptores, estudio citogenético. Este es un ejemplo muy desgraciado que tuvimos hace relativamente poco tiempo de un varón de 38 años, sano, completamente sano, que en el seno de un golpe de calor hace una hepatitis fulminante y entra en urgencia 0. Recibe el hígado de una mujer de 61 años, fumadora de 2 paquetes año y con cardiopatía isquémica, broncopatía, placa de tórax normal, luego podemos discutir esto, solo fue donante hepático, no hubo tejidos y no hubo otros receptores. A los 14 meses del trasplante, el paciente empieza con una alteración analítica, con prurito, y se hacen pruebas de imagen diversas y se ve múltiples loes hepáticas, adenopatías suprainfradiafragmáticas y se diagnostica un carcinoma microcítico de pulmón altamente diferenciado. Y en el estudio citogenético, que además ya se veía que las células tumorales eran XX y no XY, como el receptor, por lo tanto ya se sospechaba que venía del donante, citogenéticamente se demostró el origen en el donante. Pese a 4 líneas de quimioterapia, el paciente desgraciadamente falleció 12 meses después del diagnóstico. Aquí tenéis las imágenes por PET a los 14 meses y cómo va progresando hasta el momento en el que desgraciadamente el paciente fallece. Por lo tanto, hizo falta un estudio, es una presentación muy típica, los 2 primeros meses post-trasplante, el injerto infiltrado por tumor con metástasis a distancia, un tumor que no parece proceder del donante, pero siempre estudio citogenético para confirmarlo. La gestión, ¿qué hay que hacer en la gestión? Bueno, pues evidentemente no hay unas recomendaciones sólidas de qué hacer ante estos casos, es un análisis muy individualizado, va a depender del tipo de tumor, de la situación en la que se encuentre el receptor y, por supuesto, caso por caso tendremos que valorar la opción del retrasplante. Lo que sí me interesa incidir es que cuando nos encontramos ante este tipo de situaciones hay que hacer un estudio del caso por parte de todos los implicados, vigilar y revisar si hemos hecho algo mal, nos hemos desviado de algún protocolo, si hay algo que podríamos hacer de una manera diferente para que esto no vuelva a ocurrir y para minimizar la ocurrencia de estos dramáticos incidentes. Pero además, en el sistema de biovigilancia es necesario realizar un informe que recoja toda la experiencia del caso con el objetivo de documentar esa situación como oportunidad de aprendizaje no solamente para el centro que ha vivido esta situación, sino para toda la red, porque de ello aprendemos y vamos modificando nuestros protocolos y nuestras pautas de actuación. Bueno, para finalizar, nosotros con este abordaje de el donante que conocemos a priori, el tumor que conocemos a priori o el tumor del donante que conocemos a posteriori, nos hemos visto obligados o creemos que tenemos la obligación de generar evidencia, porque esto es lo que realmente nos va a permitir delimitar bien cuándo podemos y cuándo debemos proceder con el trasplante y cuál es el riesgo que asumimos. Tenemos dos programas. El programa de donante de riesgo no estándar consiste en un seguimiento prospectivo de los receptores de donantes con determinadas condiciones que son transmisibles al receptor, como puede ser una patología neoplásica. Se recoge un mínimo conjunto de datos de estos receptores con una frecuencia que depende de la condición del donante por parte de los coordinadores o los propios equipos de trasplante. Muchos de vosotros participáis en este programa a través de una plataforma web de alta seguridad o de una aplicación móvil. Cuando hemos visto que se activa una alerta de biovigilancia, aparte de todo lo que tenéis que hacer de alertar, investigar y gestionar el caso, también se activa un seguimiento prospectivo de los receptores idéntico al que realizamos en el programa de donante de riesgo no estándar. Bueno, estos dos programas nos han permitido revisar muy recientemente nuestra experiencia con donantes con patología neoplásica que se acaba de publicar en la revista Transplantation. Fijaos que hemos analizado más de 10.000 donantes de órganos, de los que al menos se había trasplantado un órgano durante el periodo 2013 a 2018. Y nos hemos encontrado con estos tres escenarios. En el primer escenario, en 275 donantes, es decir, casi un 3%, hemos trasplantado órganos de donantes de los que conocíamos a priori que había una patología tumoral, bien en los antecedentes del donante o bien en el momento de la extracción. Y fijaos que en ocasiones, en 23 casos, el riesgo se consideró intermedio según la clasificación del Consejo de Europa y en 10 casos se consideró de riesgo alto de transmisión. 651 receptores, tras una mediana de seguimiento de 2 años, no se ha diagnosticado ninguna transmisión tumoral. Segundo escenario, 64 donantes, el 0,6% de la muestra, fueron diagnosticados de un tumor cuando ya se había realizado el trasplante sin que esto derivara en ninguna transmisión tumoral. Estos tumores, que fijaos que algunos eran de riesgo alto, incluso de riesgo inaceptable, se diagnosticaron muy rápidamente después del trasplante. De hecho, el escenario más habitual, en prácticamente más de la mitad de los casos, era un cáncer renal identificado en la cirugía de banco cuando el resto de los órganos estaban trasplantando. Bueno, pues de los 126 receptores en riesgo, fijaos que no se ha producido ninguna transmisión tumoral, si bien en 5 casos tuvisteis que hacer una trasplantectomía profiláctica porque se consideraba que el riesgo realmente de transmisión era muy elevado. Y veis que hemos tenido 10 donantes, de los que se han trasplantado 25 receptores, que sí produjeron una transmisión tumoral a 16 pacientes. Se trató de 9 casos de cáncer de pulmón. Fijaos que cambia la histología con respecto a lo que hemos visto en otras series. 2 de cánceres de duodeno, 2 renales, un colangiocarcinoma, un cáncer de próstata y un cáncer altamente indiferenciado. Tras 30 meses de seguimiento de mediana, fijaos que se han producido 10 pérdidas del injerto y 9 fallecimientos directamente relacionados con este tumor transmitido, luego una evolución fatal. Esa es una tabla muy complicada, pero ya termino. Os voy a guiar a la hora de comprender esta tabla. Estos son los 349 donantes por tipos de tumor que hemos tenido con patología tumoral identificada antes o después del trasplante, 802 receptores de estos donantes y aquí tenéis un 2% de ellos, 16 pacientes que desarrollan esa transmisión tumoral, 15 que pierden el injerto como consecuencia del tumor y 9 que fallecen como consecuencia del tumor. La tasa de transmisión tumoral en la experiencia española con donantes envejecidos y donantes con una enorme comorbilidad, fijaos que es de 6 casos por cada 10.000 trasplantes efectuados. Y sí que me interesa que sepáis que tenemos toda esta información y además por tipo de trasplante, porque es una información que os puede ayudar cuando os encontréis con una situación como esta. Fijaos, por ejemplo, de tumores del sistema nervioso central hemos tenido 279 receptores, es verdad que casi siempre han sido tumores de bajo riesgo de transmisión, no se ha producido ninguna transmisión tumoral. Os llamo la atención también sobre el cáncer de células renales, 116 pacientes de diferentes tipos de órganos se han trasplantado con donantes con un cáncer renal. Hemos tenido 2 transmisiones. Y las dos transmisiones han ocurrido en dos receptores renales, con un diagnóstico incidental. En un caso fue en una biopsia por sospecha de rechazo agudo y en otro caso se hizo una trasplantectomía por una no función primaria y en la anatomía patológica se identificó el cáncer. No se han producido más transmisiones. Esto es muy importante porque habéis visto la frecuencia con la que nos encontramos con cánceres renales en el momento de la cirugía de banco cuando otros equipos ya están procediendo con el trasplante. En el caso de la próstata, 91 receptores de donantes con cáncer de próstata. Hemos tenido una transmisión en un receptor hepático en el que no se conocía el antecedente de cáncer de próstata en el donante. Y lo que sí que nos preocupa y quizá nos tiene que llevar a modificar nuestros protocolos de actuación es lo que ha ocurrido con el cáncer de pulmón. Hemos tenido 21 receptores de donantes con cáncer de pulmón identificado antes o después del trasplante. Fijaos que en 9 casos se ha producido transmisión y 7 de estos pacientes han fallecido. Luego, el cáncer de pulmón para nosotros, probablemente por el perfil de los donantes en España, es el que más nos preocupa a día de hoy. Por lo tanto, y en conclusión, los donantes con una historia actual o pasada de enfermedad tumoral pueden contribuir a incrementar la disponibilidad de órganos para trasplante tras un análisis individualizado y cuidadoso del riesgo-beneficio. Las recomendaciones españolas, que son las europeas, constituyen una adecuada guía para la toma de decisiones y para informar a nuestros pacientes en lista de espera, si bien para algunos tipos de tumores, por lo que estamos viendo, y os llamo la atención sobre los tumores del sistema nervioso central, quizá estamos sobreestimando el riesgo de transmisión y perdiendo órganos que podían ser válidos para trasplante, y por ello necesitamos incrementar el nivel de evidencia. Y esta aproximación doble, prospectiva y estandarizada que hemos tomado en España creemos que nos puede ayudar a aumentar este nivel de evidencia. Y finalmente, los receptores en lista de espera deben ser informados del bajo riesgo, pero no el riesgo cero de que se produzca una transmisión tumoral. Si bien existen medidas, y yo creo que podemos discutir ahora si queréis del tema del cáncer de pulmón, por el que podríamos introducir en el proceso de caracterización del donante para reducir aún más el riesgo de transmisión tumoral. Con esta frase de Henry Ford que decía: unirse es el comienzo, mantenerse unidos es el progreso, trabajar juntos es el éxito. Termino porque realmente creo que aunando todos los esfuerzos que hemos aunado en estos dos proyectos es donde vamos a encontrar la respuesta a muchas de nuestras preguntas. Muchas gracias por vuestra atención.
Gracias, Beatriz. ¿Alguna pregunta en la audiencia? Sí, la doctora de la Torre. Sí, te levantas aquí.
Buenas tardes. Gracias, Beatriz, por toda esta información que es tan interesante para los que nos dedicamos al trasplante. Yo soy Mercedes de la Torre, del equipo de trasplante pulmonar de A Coruña, y un poco viendo lo que es los que vivimos el pulmón, el cáncer de pulmón, el trasplante de pulmón. Y aunque los donantes pulmonares que aceptamos fumadores, creo recordar que es un 14% en el 2021, son muy pocos, siempre nos planteamos cuando hablamos si a los donantes fumadores deberíamos hacerles un TAC, porque al final, pues si son pocos, es algo fácil de hacer. ¿Cuál es tu opinión en este sentido?
Pues efectivamente, Mercedes, eso es lo que estamos hablando. Vista la experiencia y visto el perfil de donantes que tenemos, desde luego esto es algo que nos deberíamos plantear. La cuestión es que es cierto que a veces cuando se nos proporciona información sobre los hábitos de riesgo del donante, muchas veces se nos dice que es fumador, no se nos especifica más. Y bueno, aquí el debate está: se hace un escáner a todos los donantes, hacemos un escáner a donantes con perfil de riesgo y quizá deberíamos, pero desde luego a los donantes con un hábito tabáquico elevado y quizá bueno, pues el punto de corte deberíamos delimitarlo, sí que deberíamos tener un escáner. De hecho, el caso que os he presentado pues era evidente, o sea, ahora retrospectivamente lo vemos y decimos, hombre, si hubiéramos hecho un escáner a esa donante, pues lo mismo habríamos detectado algo o no, tampoco lo sabemos. Pero sí, yo creo que ha llegado el momento, vista la experiencia y bueno, después de 2018 hemos tenido algún caso más de transmisión de cáncer de pulmón, es que casi siempre son cánceres de pulmón. Yo creo que sí que nos tenemos que plantear ya sistemáticamente en determinados donantes el escáner, que muchas veces además lo tienen hecho durante su ingreso, o sea que yo creo que sí, que tenemos que introducirlo en nuestra práctica habitual. Estoy contigo.
¿Alguna otra pregunta? Pues Beatriz, una pregunta que te quisiera hacer yo sobre los donantes del sistema nervioso central. La mayor parte de los donantes con cáncer pues son pacientes con cierta edad, pero en el caso del sistema nervioso central solemos encontrar donantes jóvenes con un glioblastoma o un tumor, bueno, pues de los de riesgo intermedio. Nos has puesto los datos de los que se han trasplantado, pero un poco la impresión que tenemos la gente de la UCI o de coordinación es que tenemos muchos donantes de ese tipo, o sea, bastantes donantes de tipo, que tienen muy poca transmisión a nivel cardíaca, por ejemplo, con una lista de espera en corazón de casi el 50% de trasplantes en la alarma cero, y la impresión que tenemos, claro, es una impresión yo de mi hospital, es que el uso de estos donantes es mínimo, cuando son donantes realmente ideales, donde quizá el receptor, si se le plantea recibir un corazón de 30, 35, 40 años, que es el habitual, pues era un poquito saber los datos de los que no se utilizan. ¿Qué tasa tenemos? ¿Qué nos puedes decir?
Bueno, es difícil porque muchas veces lo habitual es que no se nos notifiquen los donantes, aunque a veces sí que perdemos muchos casos, pero se ha hecho un estudio recientemente en Murcia que estimaba que cada año en la región de Murcia fallecían 15 donantes de edad, 15 personas, perdón, de edad inferior a 55 años por un tumor grado 3 o grado 4 del sistema nervioso central. De hecho, consideraban que podían alcanzar la autosuficiencia cardíaca en particular recurriendo a este tipo de donantes, porque es cierto que en el ámbito del trasplante cardíaco, aunque se ha transmitido algún caso, es particularmente infrecuente la transmisión tumoral. En este sentido, particularmente el Hospital Virgen de la Rissaca sí que ha iniciado un protocolo de actuación frente a donantes con tumores malignos del sistema nervioso central. Es un proceso que es complejo, porque claro, aquí no estamos hablando de un donante que esté en UCI. Habitualmente no va a ingresar en UCI, salvo que sea un diagnóstico en una intervención quirúrgica con una complicación posterior que el paciente fallece en UCI. Estos pacientes están en cuidados paliativos domiciliarios, con lo cual nos estamos planteando un escenario de ingreso para la sedación paliativa terminal del paciente, llegado el momento, y activar un proceso de donación en asistolia cardíaca, que es un poco rizar el rizo. Pero es lo que se está planteando este grupo de la Rissaca y ya ha hecho algún caso. Creo que cardíaco todavía no, de hecho, pero sí en pacientes en una situación crítica en la lista de espera. En fin, seguiremos recopilando experiencia y con ello veremos la forma de seguir adelante.
Perfecto, pues si os parece, seguimos con el siguiente speaker.
Bueno, ahora el siguiente ponente es el doctor Marcelo Cipel, cirujano torácico de Toronto, en Canadá. No sé si está...
Sí, ya está ahí.
Sí.
Good afternoon. Hello.
Can you hear me?
Good morning in Toronto, I think. For us, we are glad and very happy to come with you in this session. Wherever you want.
Gracias por la oportunidad. Yo hablo un poco español, pero yo voy a presentar en inglés, porque si no voy a ser muy devagar, ¿ok? Pero si hay alguna pregunta en Spanish, está bien.
Perfect, thank you.
Yo estoy en Boston ahora, pero la hora es la misma que Toronto, so es casi mediodía acá. Yo voy a share my screen. Just 1 second.
Okay, perfect.
Can you see my slides?
Yes, we can.
Can you hear me?
Yes,
Yeah.
Marcelo, we can hear you.
It's all good?
Yeah, perfect.
Yeah, okay, good. So I'm going to talk about lung transplantation in COVID. Again, thank you again for the invitation. I'm sorry I cannot be there in person this time, since we're having our American Thoracic Surgery Conference now. But The ARDS, I think it's a well-known condition where, of course, many patients with COVID had that definition of severe ARDS, where they are treated with mechanical ventilation, prone position, nitric oxide, and then a subset of them need the use of ECMO. The use of ECMO in COVID basically is the use of venous-venous ECMO, either with a two-cannula approach or with a single-site dual-lumen cannula like the Crescent cannula. And so the vast majority of the COVID patients, they could be well treated with venous-venous ECMO. A very small subset needed some cardiac. To give you an idea, we have a very centralized system in Canada where basically most of the ECMO cases or the patients that needed ECMO for COVID in the province of Ontario, which is a 14 million catchment area, would come to our hospital. So, these are high number of ECMO cases, but you have to keep in mind that pretty much in our hospital, in our ICU, we would only get patients with COVID when they needed ECMO. And so this is the average, so 142 cases. We had over the second half of the year an additional 40 patients, but this just to give an example. And average age 47, most were male, and average time on ECMO was three weeks, and 8 patients received lung transplantation after several weeks of ECMO, so far with excellent outcomes. This is just to show you here, we had a time where we had 34 patients on ECMO in our unit for COVID at the same time. And so you can imagine, you need a lot of hospital resources dedicated for that. The indications for ECMO for COVID were very similar in general to ARDS for other, from other causes, although we were a little bit more conservative in some aspects. So, for example, of course, the hypoxemia and or persistent hypercapnia were the main indications, and we had limited our patient population at 60. We had a few patients between 60 and 65 that we put on ECMO, but we tried to limit around 60. And of course, patients with significant medical problems or extremely high BMI, we would sometimes not consider. And duration of mechanical ventilation, very important, because if they have already more than 10 days of ventilation, they don't tend to do well. And of course, many of the other contraindications for ECMO in general. This is just to show in the 3 waves. Again, we actually had a increase in the number of ECMO use over the different waves, and the survival was in the range of 50%, which is lower than we used to see for example, for influenza patients on ECMO at our unit, which we have about 70% survival. This is again just how this compared to the ELSO experience. Again, the in-hospital mortality was in the range of 50% in the ELSO experience, which was very similar to what we observed at our hospital. Now, one of the major factors related to survival of this patient population is the center experience with ECMO. So if you do normally before the pandemic more than 30 cases a year of ECMO, you have better survival. And of course, age was a major factor for COVID here. You can see, patients with more than, 57 years of age did a lot worse. And again, the time from intubation to ECMO was also another thing very important for overall survival, with the best outcomes for patients were on ECMO within 3 days of mechanical ventilation. You have to keep in mind that many of these patients were already on non-invasive ventilation prior to being intubated, and so the time of ventilation itself was higher than that. Now, there are three possible outcomes for patients with COVID ARDS. As I showed you, unfortunately, 50% of them die from complications related to COVID or ICU related. And then you have the other 50%, the majority will have lung recovery and survive, but you do have a subset of patients that have absence of lung recovery, and that's the situation where we will consider bridge to transplant consideration. There are two scenarios that patients can be bridged to transplantation in COVID. The first scenario is the most common one, which is the patient in the acute phase of COVID. So that's the patient that is ECMO dependent. You can take them off ECMO. They have very extensive lung injury, and then you list them for transplantation. The second scenario is the patient that is just lingering in the hospital with needing oxygen at higher concentrations. Sometimes they may not be intubated, but they just don't improve and they develop some lung fibrosis. And sometimes you may have to use ECMO as a means of rehabilitation and supporting these patients, or just list and transplant them. So in terms of consideration for lung transplantation, the current evidence is still limited to case reports. And of course, there is some registry data now from UNOS as well with, over 100 cases. But it's still unclear the rationale for proceeding with listing and the timing. And, isolated reports basically have shown that, Vienna and Northwestern and University of Florida and some other European centers have had good success, again, with a limited number of patients being published. If we look at the communication, the first few patients, one was done at Vienna and then in Italy, and then Northwestern in Chicago, and then University of Florida. These were kind of I would say, the pioneers in the transplant in this area specifically. And then Arizona. And last year at ISHLT, there was a presentation of lung transplant for COVID of 36 patients, again, multi-center, and, different institutions here. And you can see the age of the patients, 51 years of age was the average, and BMI 25. So the very obese patients, they will end up not being listed. And these are blood types. And you can see here that these patients were extremely sick. 97% of them were on VV ECMO. And 61% also had right ventricular dysfunction, which is a very common scenario in these patients with some destroyed lungs. All cases were bilateral transplantation done with a clamshell incision. And this, you can see here that this, in general, they seem to be more difficult transplants, although I have to say the 8 cases we did in Toronto, only one of them was a challenging case. That was a patient that had empyema. The other 7 patients, the transplant technically was very similar to patients with pulmonary fibrosis, although, of course, the patients do bleed more because they are on ECMO already for several months. But you can see here that they receive more transfusion than usual, like 8 units and FFP and so on. And 64% of them, they stay on ECMO, on VV ECMO post-transplant. But they have very good result overall, and 100% day survival in this limited experience. When you look at 3-month survival, 91%, and again, long-term lung function, no one really knows so far, but we haven't seen any flags about high incidence of acute rejection or other problems. So I just want to show you a couple of cases from our center. So this is a 64-year-old, previously healthy. This was our first transplant patient. We put this crescent cannula which is a dual lumen cannula, and the patient had extensive lung disease. He was already on ECMO for a couple of months when he was listed, and then he received a double lung transplant, and he was weaned from ECMO in the OR. And he did very well. He stayed in hospital 37 days post-transplantation, which is quite remarkable if you think that these patients were in hospital for 3-4 months in an ICU prior to that. And so they can be quite deconditioned, but they do recover much faster than we used to see patients with end-stage lung disease that are bridged to transplant on ECMO. We tend, in all of these cases, we did with a clamshell incision and central ECMO. So what we do here, we keep the venous ECMO running in parallel, and we do a central cannulation of the right atrium and ascending aorta. And so we have the two ECMO circuits. At the end of the case, we take the central VA ECMO out, close the chest, and then trying to wean the VV ECMO if the lung function is good. Yeah, so this is just some of the picture of the patient that was transplanted. So this is another patient, 53-year-old, also, kind of lingering with non-invasive ventilation for like 2 months, and then had an abrupt worsening of shortness of breath, and then he was intubated and proned, and then transferred to us on paralysis. And then in this patient, we inserted this cannula called Protect Duo cannula. You can see here, this is a dual lumen cannula similar to the crescent cannula, but instead of sitting in the IVC, it goes to the pulmonary artery. So it functions also as a right ventricular assist device, a percutaneous one. And one of the advantages of this cannula is that it also provides some support to the RV and has basically zero recirculation. So it's a useful cannula in some situations for bridge to transplant. Again, this is the CT of this patient, and he received a double lung transplant and was also weaned from ECMO, and he left ICU 6 days post-transplant. Again, showing how interesting these patients can recover quite fast. And this was a sicker patient, 48-year-old, with a single organ dysfunction. Again, the lungs were fairly consolidated, and here just to show also some bronchiectasis and some bullous destruction. And he was transplanted with bilateral lung transplant. You can see him here in the ICU on ECMO. This is 11 weeks on ECMO prior to the transplant. He was able to communicate and consent for transplant, which we think is something very important in this population that never heard about transplant before. But he wasn't able to do much physiotherapy. And despite that, we elected to go ahead and do the transplant and let the rehabilitation happen after the transplant. And that's here leaving the hospital after his transplant. So one of the major questions and challenges is really when to pull the transplant trigger. And, we don't want to do this too early, and we don't want to do this too late. And there is no really good data to support one way or the other. So the main question today is not if transplant for COVID ARDS can be done, but when should it be done? And one of the main features is, can the lung still recover after several weeks on ECMO support? And the real question is, we see that happening very often. And so this is just an example that I can show you, a 42-year-old lady that was admitted to us with COVID and was on ECMO. This is December 19. And when you look at the CT scan, you won't say that, this lung will ever recover. But then you wait a little bit and you see that marked improvement on January 9, about 3 weeks after. And then you can see here on March 18, this patient was already decannulated at this point, and she left the hospital, with fairly good lung function without oxygen. So, if you do a transplant on a patient like this, it's going to be a disservice for this patient because we all know, unfortunately, lung transplantation, 5-year survival is only about 60%. And there is a lot of morbidity issues with immunosuppression and so on and so forth. So we have to be very careful to be quite sure that the lung is no longer going to recover. But at the same time, we don't want to miss the window. And I think that's the difficult part. Dr. Barat from Northwestern has shown that some of these patients that do develop fibrosis or pulmonary fibrosis like picture, and they share many of the genes also related to pulmonary fibrosis when you take single cell RNA sequencing of these of biopsies of these lungs. So I think just to finish the legacy from COVID lung transplant, I think it's going to make a big difference how we may practice managing patients with ARDS in the future. Because we in the past, we rarely would consider ARDS patients for lung transplantation, but now we can see this is feasible and safe, but we need to standardize who, when, and how. We have to develop better markers of irreversible lung injury, and of course, work on mechanical support systems that would allow long-term support and mobilization of these patients. So this is just a take-home slide when to consider lung transplant in a COVID ARDS patient. You have to have less than 65, only single organ dysfunction, although some reports of lung and kidney transplant have been described. You should give sufficient time for lung recovery. Transplantation should not be considered in less than 6 weeks after the initial respiratory failure. We normally, we can start looking at 6 weeks, but we wouldn't consider transplantation until, probably about, 2 to 3 months of the patient on ECMO. We should have radiological evidence of irreversible lung disease, such as bullous destruction or established fibrosis. The patient should be awake and able to discuss transplantation and participate in some physical rehabilitation while on the transplant wait list. And they, of course, should fulfill the remaining criteria for transplantation, such as adequate BMI and no other important comorbidities, such as severe coronary artery disease. And then some of the COVID, negative COVID PCR, some of this part is evolving. And only centers with substantial experience in ECMO bridging should offer. And of course, you need to have a good access to a broad donor pool and low waiting list mortality, so you don't disadvantage also your patients on the wait list with end-stage lung disease. So I'd like to thank the opportunity again. I'll be happy for any questions.
Okay, thank you, Marcela, for your amazing presentation. I don't know if something in the plenary have any question. No? I prepared some questions, but in your presentation you asked most of them. I have in your presentation you said one of the contraindications for ECMO in COVID, but I don't see if, I don't know if you have any contraindication for age of the patient, or age is not a matter.
Yeah, so I think the age was something that has evolved. So, in the beginning of COVID, we started with 65, which was the usual age we consider for influenza, for example. But then we start seeing that the outcomes of these patients were poor. And so we lower our age to about 55 even. And of course, for excellent candidates between 55 and 60, we would look, and discuss as a group. So, if you have someone that is an athlete, and was great, no other comorbidities, that end up in the ICU at the age of 60, yes, we would consider then that patient, right? But these patients have a lot more complications than the usual ones, and so we try to limit the age a bit, more. And I think this has happened in other centers as well.
Okay. Yes?
Yes, another question.
Thank you, and thank you for that beautiful talk. So I'm a transplant hepatologist, and we have a gross shortage of organs. So I was curious about the point that you made of trying not to disadvantage other people who may need access to lungs. Can you just tell me, are most people who are listed in appropriate candidates receiving lung transplants? Because we are very, having to turn towards live donors because we can't get the patients who need transplant to transplant. And how do you think that's going to influence where people are actually comfortable transplanting lungs when it comes to kind of, national availability or local availability?
Yeah, I mean, that's a great question. It's a very, very difficult one to answer because there is a lot of ethics discussion on this. Our take on that was, at the end of the day, these people, they didn't choose to be sick as well. And so, I think once more data is available that they do well after transplant, and if they are very selected, I mean, it has to be a very selected group of patients, right? We wouldn't want to waste organs, if we had like a 50% survival in this population, right? But since the data now is showing that the outcomes of these patients is very similar to the patients that are on the wait list, for end-stage lung disease, I think they should be considered in an equal fashion. It was a tough, because we also had less donors during the pandemic, so patients were already waiting longer. We had a higher wait list mortality that we used to. And then on top of that, you had these patients coming. So there were members even in our team that were a bit uncomfortable, transplanting these patients. But I think we made a decision to give them a chance. And again, I think in a very selected group it's worthwhile. And I think specifically in lung, although hopefully one day COVID will go away as a cause of major lung injury, we're still going to continue to have influenza and other causes of ARDS. And I think we need to look carefully, what of these patients could benefit from transplantation as well.
Yeah. Dr. Sipel, I have a question for you. We don't have any experience with this type of transplants, but you have repeated several times in your talk that it's necessary to have the patient awake and to discuss with him about the possibility to be transplanted. My question is that so many times in the ICU with these patients, they have some kind of delirium, or they need hypnotic drugs to be stabilized, and maybe it's not possible to discuss about this topic with them. So is for you a contraindication for the lung transplantation in those cases, because it's quite often in the ICU, at least, as my experience.
This is a perfect, excellent question. We try as hard as possible to get them awake and discuss. And just to mention, this is very difficult to get to that point, especially in the first 2 months of disease. And the main reason for that too is that, COVID also induced some brain inflammation, which contributes to, delirium and agitation and inability to wake up these patients properly. But once they go beyond that phase of inflammatory phase and they get to the 3rd month or so on, it gets a little bit more feasible to get them awake and have that discussion. So out of the 8 patients we transplanted, there was only 1 patient that we couldn't really get them to sign consent, but the family was so adamant that he would like to have that done that we took the family as a decision. I just would like to mention that we had past experience with patients that, a couple of patients we transplanted without first consent, and one of these patients actually committed suicide after transplant. Okay, because it was not the life that he was expecting to have. So we have to be very careful, and this is something we try to achieve as much as possible, more than like physiotherapy. I'm okay if the patient cannot walk, in the ICU, but if they are awake and they can do some bad physio and so on and so forth, I think that's okay.
Okay. Thank you very much for your participation, and thank you very much to accept our invitation. We hope we can see you in person in 2 years in the next meeting. And
Yes.
really, thank you very much.
Great. Muchas gracias.
Gracias.
Well, it's my pleasure to introduce our last speaker, Monica Sarkar, who is going to speak about a very unusual topic in this kind of Congress, even though it has real impact on recipients' quality of life. Monica Sarkar is a hepatologist. He works in the US, and she's got a huge experience in woman liver disease. Monica, thank you very much for accepting our invitation, and the floor is yours.
Well, thank you so much for the invitation. Yo hablo poquito de español, so I'm going to have to do this talk in English, but I will talk slowly. So I have no relevant disclosures. So today we'll talk about the prevalence and the cause of sexual dysfunction as we see it in individuals who have end organ disease. I am a transplant hepatologist, so most of the data we'll be discussing will be related to liver and kidney, so solid abdominal organ transplant. We'll talk about how sexual function, sex hormone levels really change and normalize over the course of the pre to the post-transplant time period. And then really talk about how we as transplant providers can start to think about evaluation and management of some of these symptoms. So as a definition, sexual dysfunction is impaired ability to experience satisfaction with sexual activity. And it has multiple clinical manifestations. For both men and women, they'll experience decreased libido, inability to have an orgasm. For women, painful intercourse, irregular menstrual cycles. For men, we'll commonly see erectile dysfunction, and then particularly with patients who have end organ liver disease, we'll start to see manifestations of feminization. So who cares about sexual function? I think for many of us, we are focused on our organ and taking care of the management of that specific organ. But it's actually a really important quality of life metric to our patients. So the majority of patients who are listed for pre-transplant or now in the post-transplant setting, according to a report survey that they did, felt that their sexual health and sexual function was very important to their overall quality of life. And it turns out that the majority of patients that we're taking care of in that end organ disease are going to have evidence of impaired sexual function. So it's about 60% of all women who have end-stage liver disease who are on the transplant wait list will report sexual dysfunction. And similarly, about 61% of men awaiting transplant will have severe erectile dysfunction. We see these parameters being even more severe in patients who have end-stage renal disease. So 85% or so of patients who are awaiting transplant or have dialysis will report these symptoms, and that's across surveys of both men and women. And we also know that measures of impaired sexual activity will worsen with worsening disease severity. So in the liver world, we talk about the Child-Turcotte-Pugh score. So child C is more severe liver disease than B than A. And it includes some measures of clinical manifestations as well as laboratory values. And so this was a study that was using something called the International Index of Erectile Function, and they found more severe measures with progressive liver disease. So these manifestations also translate to what we see for fertility in women. So looking at women with end-stage liver disease, about 3/4 of these patients will have, who are listed for liver transplant, will have secondary amenorrhea, meaning that they used to have menstrual cycles, and as they had progressive damage to their liver with cirrhosis and decompensation, their menses stopped. We know that incident childbirth is lower for patients who have decompensated cirrhosis as compared to the general population, with decompensation being ascites, hepatic encephalopathy, variceal bleeding. And similar to the previous slide, we know that these symptoms are much more marked in individuals who have end-stage renal disease. So the majority of reproductive age women on dialysis are going to have oligo or amenorrhea, meaning few or no menstrual periods. And even of those premenopausal women on dialysis who are having regular menses, at least half of them are not able to release an egg, meaning they're unable to actually get pregnant. There's multiple reasons, multifactorial contributors to why our patients with end organ disease are having manifestations of sexual dysfunction. And we'll start by talking about derangements at the level of the hypothalamus pituitary gonadal axis. So for women, it's very key that the gonadotropin-releasing hormone at the level of the hypothalamus is communicating to the pituitary. And that helps the pituitary to release follicle-stimulating hormone and luteinizing hormone. Now, in the setting of end organ disease, there's impairment in the release of gonadotropin-releasing hormone. So that whole connection from hypothalamus, pituitary to the ovaries to help stimulate egg development, production of estradiol, production of testosterone is all halted. And another really interesting kind of sex hormone aberrancy that we see in both liver and kidney patients is also high levels of prolactin. It's even worse, kind of exacerbated in kidney patients because the kidneys are no longer able to clear prolactin. But prolactin inhibits gonadotropin-releasing hormone at the level of the hypothalamus, further worsening this whole cascade of events. Likewise, this is the same aberrant pathways that we see in men, again with impairment of gonadotropin-releasing hormone, follicle-stimulating hormone, and luteinizing hormone. FSH is really key for men to be able to produce sperm, and luteinizing hormone is really key to help men to produce testosterone. And again, that same inhibitory effect of prolactin is very marked in the setting of men who have end organ disease. But these aberrancies really normalize quite rapidly after transplant. So here's a study that was just looking at hormone levels in women after liver transplant 3 months after their operation. And as you can see, all of these hormonal parameters are approaching normal. And it translates into what we see clinically with most female transplant recipients starting to have normal menstrual cycles within a year. But menses can resume within weeks. In fact, women can get pregnant within 1 to 2 weeks of receiving a kidney transplant or a liver transplant. So that's also a very important point when we're thinking about counseling our women about contraception, pregnancy risks, and timing that process. So this is a similar study that was conducted in men after kidney transplant. 97 men, on average about 53 years old, 5.5 years out from their kidney transplant. And you can see a steady increase in their testosterone levels from 0 to 12 months after transplant. And we see that for other hormones as well, estradiol, and again, a really pronounced decline in prolactin, which is so key for the hypothalamus to function normally after somebody has received their operation. So the impairment of the hypothalamic pituitary gonadal axis seems to resolve, and that resolves quickly. But there's many other factors that are also contributing to the symptoms that our patients are experiencing. There's the end organ effects, so hepatic encephalopathy in cirrhosis patients, systemic vasodilation, particularly in our patients with cirrhosis, that prevents them. There's a profound increase in erectile dysfunction just from inability to really maintain blood pressure. Direct uremic toxicity to the testes is really prevalent, and then weakness and fatigue that most all of our patients are feeling going into transplant. There's also prevalent depression and anxiety in our transplant population, concerns about survival, actually making it to transplant, particularly in the United States where I practice, financial burdens around whether they're going to be able to afford their transplant medications or even be covered to receive a liver transplant. Caregiver burden is no doubt a large component, with many people having to come in to help our patients to make it successfully through transplant. And then there's lots of medication side effects. So we know we use spironolactone commonly in end-stage liver disease. It's a competitive inhibitor of the testosterone receptor, so we'll see men starting to develop gynecomastia. We use non-selective beta blockers to lower portal hypertension. That has direct effects on for erectile function, and then antidepressants, which commonly have as a side effect impairment of sexual function as well. And then there's, of course, body image. So our patients are struggling with cachexia, enlarged abdomens from their ascites, umbilical hernias, bruising, jaundice. So an additional challenge in this patient population. But all of these parameters typically resolve after they get their transplant. And what we see following their operation is an improvement in most measures of sexual function. So this is a study that was looking at 91 men who'd received a liver transplant, comparing them to 21 men who are on the wait list, 17 healthy controls. And what you can see for the International Index of Erectile Function, the black bar compared to the white bar, is much better scores. So men are reporting better symptoms after they've had a transplant as compared to the men who are still on the wait list. These are smaller numbers of patients, but we see similar trends in women who've undergone a liver transplant. Again, this is looking at something called the Female Sexual Function Index, and you see much higher bar for the black bar as compared to the white bar, which is the listed patients. And this was a meta-analysis that also looked at the International Index of Erectile Function, and across the board you can see improvement of all of these measures in patients who've received a kidney transplant. So similar to the data that we see in our liver transplant population. And though we see improvement of these scores, and really truly across the board, it's really important that we're counseling our patients that these symptoms might not completely go away. So this study was looking at a small group of women who'd had a liver transplant, again using the same Female Sexual Dysfunction Index, and many of the parameters are indeed improving. But it's important to note that still 50% of these women are experiencing measures of sexual dysfunction, so highly prevalent even after they've had their liver transplant. And you can even see persistent de novo sexual dysfunction that develops after transplant. One study that was published by Patricia Burra in Italy was looking at 44 women with cirrhosis, comparing them to 54 women who'd had a liver transplant. And reports of any dysfunction was pretty common between the two, 65% pre, 60% after transplant. And this was a study that actually looked at people who reported no signs of any sexual dysfunction prior to their transplant, and about a third had new symptoms that they didn't have before. So while we kind of manage that laundry list of complications or contributing factors in the pre-transplant period, there's a whole laundry list of conditions that we have to think about in the post-transplant period that contributes to lack of complete resolution or even new onset of these symptoms after transplant. So as we all know, our patients, particularly in the context of being on calcineurin inhibitors, can develop post-transplant diabetes. They can have worsening of hypertension. They have peripheral vascular disease, particularly our kidney transplant patients. There's also medication side effects we'll talk about in a moment. So this was a study that was also using the International Index of Erectile Function, and they performed this survey in 123 men, had a fantastic response rate of about 80%. And they conducted this survey about 5.5 years after liver transplant. And what they found to be associated with persistent symptoms in the post-transplant period was presence of cardiovascular disease, post-transplant diabetes, alcohol use, antidepressant use, and angiotensin receptor antagonists. And you can kind of see this here, where there's a much higher proportion of individuals who are reporting sexual dysfunction, particularly post-transplant diabetes and angiotensin receptor antagonist use. Whether that was actually presence of hypertension or this particular agent, not clear, they didn't report that. But really important to understand that many of the medicines and conditions that our patients have and use after transplant are going to be exacerbating these symptoms. So what about immunosuppression? Could that potentially worsen our patient's symptoms? When we look at mTOR inhibitors, most data derive from sirolimus. We don't have much data on everolimus. But we know that sirolimus will result in lower testosterone levels in men and in adolescent boys who've had a kidney transplant. And that's due to some direct effects at the level of the hypothalamus on gonadotropin-releasing hormone. There may be lower sperm count in men who are using sirolimus, but there's no clear impact on the symptoms that our patients are actually telling us that they have. For calcineurin inhibitors, there was a recent study that showed no difference in sexual dysfunction per these female sexual index function when you look at kidney transplant patients on tacrolimus and steroids as compared to non-kidney transplant healthy controls. And then there may be some decreased sperm count that's been seen in animal models, but nothing that we've identified in humans. So not really clear that as far as symptomatology, the immunosuppression regimens that we're using are contributing. We do have to recall some direct organ effects. So while many of the symptoms of end organ disease have resolved after someone has received their either kidney, liver transplant, there can be irreversible damage from chronic uremia, especially toxicity to the gonads. Neuropathy is very common, particularly in our patients who are going forward with kidney transplants, our non-alcoholic fatty liver patients who have diabetes and hypertension going into transplant, and some autonomic dysfunction that, although might improve, may not be completely resolved. And then when we think about our patients' mood, depression, anxiety, there's so many constraints that may develop that don't go away or maybe even worsen following their transplant. Expectations of how they're going to feel, complications after transplant, new challenges regarding financial constraints and caregiver burden that we all have to consider. And of course, there's new body images. Our patients are now having scars. They may be going in and out of the hospital with drains, for example. So what can we do as transplant providers? Well, I think the first step is really to ask our patients about these symptoms and start to normalize these conversations. So this was a single center study that we conducted at UCSF at my institution, and we conducted a survey in transplant providers and patients to ask about reproductive health, sexual activity, and whether our providers are actually asking about these questions. But one piece of this survey that I wanted to share was how our patients want to learn about sexual health and reproductive health. And we provided them with a laundry list of different resources, links to access information, pamphlets to provide, referrals to women's health providers, including OBGYN. But the single most important modality for our patients was to talk to us, the transplant providers. And perhaps not uncommon is there's a lot of siloed care. These are complicated patients, and all of their care seems to be directed to our transplant clinic. So even if you don't feel comfortable in the nuances of evaluating and managing, the first step of asking that patient to validate the symptoms that our patients are experiencing to connect them with the right providers. So we'll talk about that in the next couple of slides. This was a study of Dutch providers, and they were all kidney transplant social workers, hemodialysis nurses, nephrologists, transplant surgeons, and there was very few number of providers who were actually asking about sexual dysfunction. But what providers said were the major barriers is that patients aren't asking the question. So if the patients aren't going to ask the question, I'm not going to ask the question. There's no appropriate moment to do so. And insufficient time was not a really big barrier. So I think especially maybe in the US, we're a little bit more prudish. We just have to get comfortable having this as a routine conversation when we're following up with our patients in clinic as part of their holistic post-transplant care. I was really happy that our recent reproductive health guidance, which was published on behalf of the American Association for the Study of Liver Diseases, now actually includes a formal statement to routinely ask about sexual health in our patients with liver disease. So really a call to start adding this to the things that we discuss. And again, even if we don't feel comfortable managing the nuances, referring patients as appropriate. When it comes to hormone therapy, this is another potential option to help treat symptoms, both when we think about thyroid hormone replacement as well as testosterone and estrogens. And we know that testosterone and menopausal hormonal therapy is safe in our patients with kidney transplant and liver and who've had liver transplant. That is in the absence of underlying coagulopathy or graft failure, especially liver failure, where a lot of these hormones are metabolized. Also addressing the common comorbidities, post-transplant diabetes, getting this under better control, post-transplant hypertension, talking to our patients about recurrent drinking after transplant and smoking. So they may be more motivated if they're concerned about their sexual function than maybe managing their hypertension. So another really good way to link our patients to care about symptoms that might be relevant to some of the behaviors that they have in their day-to-day life. There's also about inquiring about mood and depression and anxiety. So we could both consider getting our patients on anxiolytics, antidepressants, mood stabilizers, and then communicating. It's all about multidisciplinary management with the providers who might be prescribing these agents. And then also really guiding those providers when they want to make some adjustments to medications that have less sexual side effects. Because sometimes they need to turn to us because they're concerned about interactions with our immunosuppression regimen. So really linking them to understand what's safe, what's not safe in the post-transplant period. And then there's also medications that can enhance sexual function. So the phosphodiesterase inhibitors for men, vaginal estrogens, lubricants in women. And I don't routinely prescribe any of these, but I connect them and I reassure the primary care providers who are taking care of my transplant patients that these agents are safe. So in summary, sexual function is important to our patients. It's an important quality of life metric that we, when we're focused on our individual organ, might not necessarily consider. And transplant does typically restore fertility and it improves sexual function. But sexual function may persist and may even potentially worsen. So it's important to have that conversation to gauge where your patient is regarding their symptoms. And inquiring about sexual dysfunction is the first step. It really opens the door to that communication because our patients may not feel comfortable bringing up a very sensitive topic, nor feel that we as providers think that it's relevant unless we ask about those particular symptoms. And we have many tools in our toolbox to address sexual dysfunction, and this is multidisciplinary management. So if you walk away with nothing, I think the take-home point is ask the question and you can connect individuals with the right specialist to make sure that they have the correct evaluation and receive the appropriate medical treatment because these are conditions that we can help to improve in our post-transplant population. So muchas gracias and si hay tiempo para preguntas.
Thank you, Dr. Sakar, for such a great talk. ¿Alguna pregunta? Dr. Sakar, I have a question. I'm intensivist, so I don't see the patients once they are discharged to the ICU, and I don't see them in the long term. But when I knew I had to chair this session, I asked to my colleagues, the cardiologists, pneumologists, pathologists, and all of them told me the same. It was more often to ask about this sexual dysfunction in men than in females. So do you have the same experience, or what's the reason why?
Well, I personally experienced that my male patients are much more likely to ask me about erectile dysfunction than my female patients are to come to me to talk about their symptoms. So there could be cultural norms around what people feel comfortable sharing. But then when you look at the International Index for Erectile Function, that came along years before the female sexual function, that index. So we know that we've developed tools to evaluate these parameters in men long before we have for women. There's also medications that have been used to treat men and impotence in men that have long preceded any medications that have become available to help treating women. So I think it's something that we've always prioritized, perhaps because our male patients are more comfortable bringing this up, perhaps because we developed measures or metrics to measure that in men before we ever did in women. But now I think it's better time than any to be making sure that we're routinely asking both men and women about these symptoms because it appears to be equally important to them.
¿Alguna otra pregunta?
No sé si tenemos tiempo para una. Yeah. Thank you for your presentation and for show us a topic that, as me as a surgeon, I think in 13 years of experience, only one patient asked me about, and I think it's very important and we don't think about. I feel very surprising that 34% of women appear sexual dysfunction after liver transplant, you know? And
say that again, 34% of women.
Yeah, I'm sorry, yeah, 34% of liver transplant women have sexual dysfunction after transplant.
Yeah.
And I don't know if this situation, do you explain them before transplant? Do you advise or do you think that we should do it before transplant?
I think before transplant is tricky because when I gave you that crazy long list of the contributors pre and post, many of the factors in the pre-transplant period improve. But I think one factor that seems very tightly linked with sexual dysfunction are metabolic comorbidities. So I think optimizing metabolic comorbidities in the pre-transplant period could be a really lovely way to mitigate some of these risks in the post-transplant. Nobody has looked at this over the course of the pre to post-transplant period to see how these measures improve over time. But we know hormonal measures improve very quickly, but we've removed that from the equation, and yet there's still such highly prevalent dysfunction that our patients are reporting. So I think that's when it comes down to looking at other factors, and I think metabolic conditions appear to be a very strong one.
Okay, thank you.
Bueno, ¿alguna otra pregunta en la audiencia? Dr. Sakar, thank you very much for this topic. It's amazing and so proud for being here. Muchas gracias a todos. Si os parece, para ir en tiempo, terminamos la sesión y gracias a todos por su asistencia. Buenas tardes.